I would like to thank the African Society of Human Genetics. It's a great honor to have the opportunity to present our work. My name is Andréa Régina, and here is a report of the activities of the Division of Human Genetics of Dakar on identifying chromosomal abnormalities in patients with suspected congenital disease in Senegal. Genetic disorders are generally fall into three main domains: the single gene defects, the multifactorial conditions, and the chromosomal abnormalities. These chromosomal abnormalities are defined as a structural or numerical alteration in one or more chromosomes. They are common. In effect, 0.4 to 0.9% of newborns have chromosomal abnormalities, and half of them have an abnormal phenotype. The chromosomal abnormalities generally fall into two main categories: the structural abnormalities and the numerical abnormalities. The structural abnormalities are genomic rearrangements on one or more chromosomes. They result from an unequal exchange between chromosomes or misrepair of true chromosome breakage, leading to different types of abnormalities like translocation. We have, for example, the translocation between chromosomes 9 and 22 in the acute myeloid leukemia with fusion genes. We also have deletions, for example, 5p- syndrome, duplication, and more. The numerical abnormalities are most common than the structural and consist in a gain or a loss of one or more chromosomes. They are divided into two types: the aneuploidy and the polyploidy. The aneuploidy is the presence of an abnormal number of chromosomes. For examples, we have the Down syndrome with 3 chromosome 21 and the Turner syndrome with a less of one of the X chromosome. The polyploidy is a condition of possessing more than 2 complete sets of chromosomes. For examples, we have triploidy with 69 chromosomes instead of 46, and tetraploidy with 92 chromosomes. The chromosomal abnormalities can affect both autosomes and gonosomes and may occur either as a result of error in the germline cells with mutation in the first or the second divisions, called non-disjunction of the chromosomes, or may happen after, during the embryogenesis, in the mitosis, in which case only a proportion of cells will be affected. We talk about mosaicism. The normal sexual development is a synergic orchestration of numerous. It implies two distinct processes: the sex determination and the sex differentiation. The sex determination takes place at the genetic phase with the fertilization. At this moment, we have the XX or the XY given by the parents and the differentiated gonads. Because the XX and or the XY are similar gonads, they need differentiation in male or female organs. That is the sex differentiation with the influence of genes like SRIG. Any problem happen in the normal sexual development can lead to disorders of sex development, DSD. There are congenital conditions defined as discordance in the chromosomal, gonadal, and anatomical sex. They affect 1 on 2,000 to 1 on 4,500 children born each year. They are the result of a deviation from the typical progression of sex development, including genetic variation, atypical development programming, and change in hormones. The SRI gene, sex-determining region, localized on the chromosome Y, the short arm of the chromosome Y, triggers the cascade of molecular events leading to male sex development. In effect, the SRY gene functions as a transcription factor, testing determining factor, TDF, leading to the differentiation of the B potential gonads into testes during the 6th week of gestation. This image shows the influence of the SRY gene on the indifferent gonads. In the presence of the SRY gene, the indifferent gonad differentiates into testes for the male sex development. When the SRY gene is absent, the indifferent gonad differentiates into ovary for the female sex development. The diagnosis of the chromosomal abnormalities. Many new molecular techniques have been developed for chromosome analysis, but the karyotyping is still the gold standard for chromosome analysis. It allows to identify the numerical chromosome anomalies and some structural abnormalities, and it also gives the genetic sex. The molecular screening is based on the polymerase chain reaction, PCR, and it permits the search of specific genes. In our case, the SRY gene. In Senegal, the socioeconomic and the cultural aspects impact the management of these conditions. We are in a poor resource country, and the diagnosis of congenital disease were expensive because samples of patients were sent abroad for chromosomal analysis. In a society when the first question new parents and family asking is, it is a boy or a girl, the question remains unanswered for newborn with sexual ambiguity. Their condition become a taboo subject while they need the diagnostic of their condition and the confirmation of the genetic sex. Based on this observation, since the ninth meeting of the African Society of Human Genetics in 2016 in Dakar, efforts were made for having an infrastructure for patient care. And then the Human Genetic Division was created in 2018. Our aim is to do the report of the cytogenetic diagnostic activities of the newly implemented Division of Human Genetics of the Faculty of Medicine, Pharmacy and Dentistry at the Cheikh Anta Diop University of Dakar. The experimental approach was a case study. From January 2020 to May 2021, patients were referred to the Division of Human Genetics from different hospitals in Senegal. They were referred for karyotyping and/or molecular screening of the SRY gene. The clinical evaluation is the first step in the diagnosis. It is based on the physical signs and symptoms that lead to the suspicion of chromosomal abnormalities or the observation of sexual ambiguity. The procedure of the standard karyotyping is the following. We take first 5 milliliters of venous blood of the patient. This total blood is placed in a culture medium, the lymphomedium, for a culture at 37 degrees for 3 days. After these 3 days, we use colchicine, a mitosis blocker that arrests cells in metaphase, and we proceed with hypotonic shock to break the nuclear membranes. Then, the cells are fixed with a mixture of methanol and acetic acid, spread onto slides by dropping, digest with trypsin and stay with GEMSA, and we analyze the mitosis with the SmartType software for having the karyotype. The screening of the SRY gene is based on the PCR, with the use of specific primers and a specific PCR program. The results we obtain are the following. For a total of 30 patients, we had cases 80 cases of numerical abnormalities, and 7 cases of disorders of sex development. The age groups of our study population were as shown in this table. For 0 to 2 years, we have 40 cases. 2 years to 12, 4 cases. 12, 5 cases. And for the 18s and others, 7. The chromosomal abnormalities observed in our patient are listed in this table. For the autosomal abnormalities, we have 8 cases of Down syndrome, 2 cases of Edwards syndrome, and 1 case of monosomy 18 in mosaic. For the gonosomal abnormalities, we have 6 cases of Turner syndrome. For the 6th case, we have 5 cases in mosaic, and we have 1 case of Klinefelter syndromes. Here we have the karyotype we done in the lab with the SmartType software. So here we have an example of patients with Down syndrome. On the right, we have a female with the Down syndrome, and on the left, a male with Down syndrome. This is a karyotype of a male with Edwards syndrome. We can see the 318 chromosome. This is a female with mosaic. We have 2 population of cells, 80% of 46XX and 90% of 40 minus 18. This is a type of patient with Turner syndrome in mosaic. We have 80% of 46XX and 20% of 45X. And then we have a karyotype of a patient with Klinefelter syndrome. For the screening of the SRY gene, we have here the result of an electrophoretic migration on agarose gene of PCR products for the SRY gene screening. So for the patient P1 and P4, the SRY gene is present. We see a band at 400 base pair, and for the patient P2 and P3, the SRY gene is absent. The test is negative, confirmed by the negative control. For the 9 patients with disorder of sex development, the results of the search of the SRY gene were confirmed by the karyotype. All the patients with a SRY gene positive had a karyotype 46XY, and all the patients with SRY gene negative had a karyotype 46XX, except for 1 patient that we're going to talk about later on. Concerning the age group of our study population, the majority of our patients had between 0 to 2 years. Their conditions were diagnosed at birth because we don't have a prenatal diagnosis in Senegal. While in certain countries like South Africa, European or American country, the prenatal diagnosis is done for the chromosomal abnormalities. The second group, age group of 8 years and older, represents 23.3% of our population. This shows that there is a late diagnosis of chromosomal abnormalities and also DSD because the poor information the population have about patient care. A further reason lies is the fact that the DSD are a taboo subject in our society. Our results show also a high frequency of chromosomal abnormalities. The most frequent we have in our population is the Down syndrome, with 44.4%. Of course, this is the most common autosomal trisomy, and it affects 1 on 700 live births. The second most frequent was the Turner syndrome, with 23.3%. This is the most common sex chromosomal abnormality in females and the most common genetic cause of primary amenorrhea. In our population, we had 5 cases in mosaic, and these mosaics were very considerably from individual to individual, from mild to severe signs and symptoms. We also had 2 cases of Edwards syndrome. This is the second most autosomal trisomy, and it affects 1 or 3,000 to 150,000 live births. We had also one case of Klinefelter syndrome. It affects 1 of 500 to 1 on 1,000 newborn males, but it's still underdiagnosed in the African context. In our population, we have found a monosomy 18 in mosaic. This is a deletion of one of the chromosome 18, and our patient had symptoms of an homogene Edwards syndrome. In the literature, we only found a monosomy 18p, and it affects 1 on 50,000 live-born infants with a very moderate and non-specific symptoms. We also found in our population a very interesting case. In fact, it's a patient with a karyotype 46XY, 46XX that we have considered as a chimera. The patient was referred to the lab because of sexual ambiguity. So we done the karyotype, and then the screening of the SRY gene came out negative. The chimera is the fusion of 2 different zygotes in a single embryo. But for our patient, we found that her mother have the same karyotype. So the question is, can we still talk about chimera? More investigation are needed, such as genotyping. The determination of the genetic sex in patients with DSD is crucial in our cultural and religious context. In fact, the parents give the name of the baby 7 days after the birth. The karyotype and the molecular screening of the SRY gene permit to obtain the genetic sex in few days. In addition to the SRY gene on the sex chromosome, on the Y chromosome, other genes localized on autosomes have been implicated in the sexual development. Genes like WT1 localized on the chromosome 11, SF1 localized on the chromosome 9, SOX9 on the chromosome 17, and other genes. These genes may be needed to be screened. So, in conclusion, we can say that our work highlights the fact that cytogenetic diagnosis and molecular screening is vital for patients with suspected congenital disease in Senegal. The management of these patients needs to be individualized, particularly for decisions related to sex rearing, surgical intervention, hormonal treatment, and potential for fertility preservation. Multidisciplinary health care is also essential for a better diagnosis. Also, the only one structure specialized in genetic disease, the Division of Human Genetics, need to be localized in the different region, but also needs equipment and new technologies upgrades like CGRH or FISH. I would like to close my talk with acknowledgements to the African Society of Human Genetics, the Faculty of Medicine, Pharmacy, and Dentistry of Cheikh Anta Diop University, as well the Senegalese Society of Human Genetics. Thanks for your attention.
Thank you very much,